Hi there. My name is Dr. Kimberly Ernest. I'm a licensed psychologist, licensed professional counselor, the president of Pennsylvania Counseling Services, the founder of Live Up Counseling, and today on the How to Be Happy Hour, we are talking about MST, multi-systemic therapy.
I'm Elise Nichols. I am the MST Director, Multi-Systemic Therapy Director for Dauphin, Lancaster, and Lebanon, the Intensive Behavioral Health Services Administrator for Dauphin County, and the Family Reintegration Program Supervisor for Dauphin County.
And my name is Jasmine Cross. I am a bachelor's level MST therapist in Lancaster County.
My name is Kate McCracken. I'm a master's level MST therapist for Dauphin County.
I'm Gabrielle Ware, and I'm an MST therapist in Dauphin County, bachelor's level.
So today, usually I lead us in, right? But I'm going to pass the mic to Elise because she is the true expert on this particular content area. So Elise, why don't you give us that 10,000-foot view of what MST is?
Yeah, so I clearly have my hands in a lot of little things, right, in Dauphin County, but it's no surprise to most people that MST is my favorite. They're all my favorite, but if I had the top favorite, MST's there. MST is can be a very challenging program and therapy, but it's also super rewarding. So a little bit about MST. We are an evidence-based practice, so there's a lot of research to back us up in our efficacy. Overall, MST as a whole, and this is across the U.S. and abroad, they have outcomes with 90% of youth living at home versus being at placement or some sort of juvenile incarceration. 86% of them at home working or going to school, so that's great. And then our big thing is 87% of no new arrests. So really having a great impact on the recidivism of youth. Personally, for our programs here, we are slightly a little bit lower than that. All of ours percentages are in the 80s, though. So we have 80% living at home, 80% working in school, and 80% with no arrests. So that's pretty awesome. There also are longevity results for this. So after 14 years, it's been correlated with 54% of fewer rearrests. And then 22 years, 75% fewer violent felony arrests. Wow. So huge impacts. So MST as a whole is designed to work with caregivers to help impact youth behavior. Our whole theory is that the caregivers have the most influence over a kid. Now, there's a lot of competing contingencies there. So we have those systemic factors coming in: school, home, peers, just culture in general. So, but our thing is those caregivers can influence all of that. So our whole goal is we're going to do literally whatever it takes to help that caregiver make some changes to those systems to help impact the youth's behavior. So our whole goal is to keep them home, out of any sort of out-of-home placement. We would like them not to have any new arrests. However, sometimes we have kids that come in with super serious felony offenses, and maybe they just get a misdemeanor offense or even just like a district magistrate citation sort of thing. So yes, technically still reoffended, but on the severity level, much better. Yeah. So MST has 3 core elements. We have our 9 treatment principles that kind of goes over all of our treatment. We have an analytic process called the do loop. So basically that is, we just get in, we identify what behaviors are going on. We ask each participant, kid, caregiver, school, probation, really anyone involved, what's your desired outcome here? Sometimes that ranges from, I just want to get off probation so I get these people off my back. That's fair. Sometimes is, I want my kid to come home. I want my kid to be in their bed at night. So it just kind of depends. So we identify their desired outcomes. We work on the strengths and needs across all those systems. So we talked about how we're systemic. So what are the strengths and needs of the peers, the school, the neighborhood? And we really use those strengths to help develop interventions. We then do something called a fit circle, which is we look at every behavior and we put it in a nice little circle. It's great. And we look at all the different factors that contribute to it. And
These are non-preferred behaviors or non-desirable behaviors?
So we would say, let's put truancy in the middle, right?
Okay.
So we have truancy in the middle, and then we're going to sit and say, what's contributing to this? Tell me what's going on here. So we'll sit and talk and say, okay, well, what does your morning routine look like? Well, I don't get up. Okay. Mom tries to wake me up. Okay. Do you set an alarm? No. So all these things. Do you know anyone at school? Do you talk to anyone at school? Some of our kids are bullied, so we have some negative peer stuff. Sometimes our kids have missed so much school that they're in technically 11th grade, but their academic level is not at that point. So they might be at a 4th grade level, and so it's intimidating to go into school. They almost feel like they're set up for failure. So all these are drivers that we look at. Once we figure out what the drivers are, we then sit and we prioritize. As a group, we pick out with the caregivers, with the team, what driver are we going to work on first? And sometimes for truancy, that could be an AM/PM routine. That could be, let's get connected with the school. Let's find one person at the school that we could leverage as a good support. And then we work on interventions to make that happen. We help them implement those interventions. Ideally, they work great. Realistically, we run into some barriers. So then we talk about what barriers do we encounter? How can we overcome that? And so it's kind of a nice little system. That's what we call the do loop, that bottom part where we implement interventions. We assess, was it good? Was it not good? If it was good, great. How can we sustain that? If it was not good, let's go back and say, what was not right with our intervention? Do we need to drill down to further barriers? Maybe we targeted something completely that wasn't the best to target. So we keep going around and around, which is great. But we do that every week. So there's supervision within that. Therapist and team, family do it together, and then we come to supervision. I look over it. We have a consultant that looks over it to make sure we're on the right path. But maybe we also look to see, hey, you didn't think about this. Let's, just in case this pops up, have a plan for this. So we continue to work through treatment like that. And then we also have a quality assurance system within MST. This is one of my favorite things personally, because this is where you can see on paper how well we are doing, but not just how well we're doing as a program, but as an individual therapist. So each month, each family rates each therapist on different measures. Are we adherent to our model? And so it'll ask, are you sure about the direction of treatment? Have you worked on school behaviors? We've worked on family relations. So there's a lot of different factors. And then we have this lovely system that we put it all in, and it generates the data. So it really tells us what we're doing good at as a therapist, but also like, oh my goodness, I didn't realize I'm really struggling on being positive and strength focused with this family, because sometimes that happens. So it helps us figure out where we need to target, which I love. But also within that, the therapists do the same thing for me and our consultant. So they measure me every other month and our consultant every other month. Are we adherent to the model? Which is nice because things happen, and sometimes I'll be real good at things, and then I might not be so good at updating their clinician development plans, although I've done better with that because that was a neat area. So it helps prioritize, and we're always continuously working and learning. So it's you're never feeling stagnant. There's always movement forward. And then as a program, we do that overall every 6 months. So every 6 months, we look at the data and say, where are we doing really well and where we're doing okay, but I'd like to see improvement. So we come up with really specific interventions for each program that I help work on and the therapists really help work on. So not only do we have a real great system of helping our families, but we use that same system to help build and maintain skills for therapists, for the supervisor, and for the program as a whole, which I love. As part of MST, we use a few different treatment modalities. They're all evidence-based, so we use behavior modification, cognitive behavioral therapy, pragmatic family therapy, and contingency management. So I can't say at one time, this is a case that I'm definitely going to say we're going to do some family therapy on, because it may be that is not the case at all. It just kind of depends when we go back to that fit, whatever those drivers are. If we identified a family conflict driver, that's what we're going to go with. And so we're going to use family therapy skills for that. If we land on a ineffective expectations, poor delivery, inconsistent, I might land on behavior modification interventions. So we're always kind of working. Sometimes we'll have multiple going at the same time, especially when we have expectations, rewards, consequence interventions. In order for those to be effective, we have to have that relationship with the caregiver and the youth. So we might be like, you know what, we got to work on that first and go do some family therapy stuff. So it's always kind of going. Overall in treatment, we really help caregivers improve supervision monitoring, structure, expectations, discipline, rewards, family relations, decreasing negative peer contact, and improving school attendance and performance. Typically, our treatment is 3 to 5 months, so where our whole goal is to get in there, do the hard work, and get out quickly. And we do that with typically 2 to 3 sessions a week. That can be a lot for a family because we're in crisis. That's a lot. We're in your face. But it doesn't have to be I'm sitting here doing, like, lay down on the couch, tell me about your life for 2 hours at a session. This is, we're action-oriented. We're getting in there. Okay, we had an AM routine. What's going well this week? What's not going well? All right, I'll come tomorrow. We'll assess together what's going on. So it doesn't have to be sit and talk about things. It's very action-oriented. We're doing it all together. So referrals, our youth, what we take is 12 to 17-year-olds. They have to have a mental health diagnosis. Typically, we get a lot of conduct kiddos, oppositional defiance, ADHD, PTSD, really pretty much anything. We don't discriminate. We'll take autism level 1, level 2 and 3 we don't. There are facets of MST that are specialized that do work with lower functioning autism or even child abuse neglect. So there are super subsets of it. We just do our typical MST for us here. Typically, our kiddos are engaging in verbal and physical aggression, property destruction, curfew violations, theft, runaway, substance use. So think of your typically, quote, delinquent kids. You know, the kids that you would think, oh, they're going to be in juvenile detention. Those are our kids, but in the community. They have to have a caregiver who's willing to participate in MST because that is our bread and butter, working through that caregiver. So it doesn't have to be a biological caregiver. It doesn't even have to be if they live with mom and dad, but grandma's there and grandma's like the primary support person, we'll work with that grandma. It can be the neighbor next door. So as long as we have someone there that can help change and impact things, we're good to go. Typically, our referrals come through county resources, so children and youth or probation, because we do have contracts with them. But we can also get referrals through psychological evaluations and written orders. Pretty much from anyone that could sign off on any of those, we can get referrals from. So we have a wide range of kids that we can see. And every referral that we get, I sit down, I go over it, I call the family, explain what it is, and really make sure they know what they're signing up for. Because we are intensive, we're a lot. And I want to make sure they're okay with that. We also have to make sure we can't take any kiddos that are actively homicidal or suicidal. Nor can we take any that their primary referral behavior is a sexual offense. We have had kids where that may have been one of their behaviors, say like 3 or 4 years ago, but right now they're engaging in theft or runaway. So because that's not the primary behavior, we can help with that. But if that is the only behavior going on, we particularly are not trained to help with that. So we refer to other resources. So a good person that would work for MST, you definitely have to be flexible, right? You have to be energetic, independent, good with communication. So not just with me, but with families, with probation. You're interacting with so many people. A desire to help others. Honestly, that's the big thing. A desire to want to help make change. To be strength focused, even in the muck of everything, when a kiddo is running the streets and maybe they have their own little like side hustle going on that like probably not the best, but there's so much resiliency in that. And we just need to use those strengths in a different sort of light. So like being able to see that, I think is super paramount to this position. That way you're not as bogged down when things get crazy, right? So being able to see those strengths. A good MST therapist is good with flexibility. They're motivated. They're okay working in the home and community, working a non-traditional schedule. So our motto is whatever it takes. We will go out to families at 7 in the morning if we have to help with an AM routine. We will go out at 10 o'clock at night if they call and say, my kid's trying to leave and I don't want them to leave. Help me out. We'll be there. We are on call 24/7. We do have a nice little rotating on call. So no one's on call 24/7. It's like 24/5. But we try to help balance that out. But we're always there for our families. So it's not a 9 to 5. It is maybe I have a session at 12. Maybe I don't have another session till 5. I've had some therapists that used to work Tuesday, Wednesday, Thursday with clients, and Monday and some Fridays for paperwork. And if that's what works for that therapist and those families, that's great. I have therapists that are very good at doing paperwork because there's a lot of paperwork where mental health can't get away with that.
Funded by
Yes.
like an
Insurance.
MCO.
Yes.
Yeah.
Insurance company. Yes. Even the counties, they like their data. They like their papers. So we got to document, right?
Yeah.
I have some therapists that are really good at doing documentation right after a session. I have some that do it at 2, 3 in the morning, which is totally fine. If that's what works for you, great. So it can be super flexible, but also it's at the needs of the family. So again, it could be mom doesn't get home till 6, so we got to go over for 6 o'clock session. We do have a small caseload of 4 to 6 typically. The reason for that is we are whatever it takes. I want to see at least 3 hours with each family a week, but there's going to be times where our families are in crisis. They need more support. So you may spend 6, 7, 8, 9 hours with the family that week. If you had a caseload of 10, that's impossible as one person. So we have a smaller caseload, helps with the balance. Each therapist is responsible to work with that family and engage everyone in that family's psychology. So you're checking in with school, probation, children and youth. If grandma, they say, hey, listen, grandma could be a support, we're going to call up grandma with a release, but we're going to call up grandma. So we're really getting everyone involved. We are also making sure that we're following the model. So it's very much, yes, we're action-oriented, but we're doing all the steps that we identified in supervision. And myself and our expert are going to hold the therapist accountable to that. The therapist does get clinical supervision weekly, so they get an hour and a half with the supervisor, me, once a week, and then we get an hour with our consultant on top of that. Supervision is very structured. I do prep for that. I figure out what are the strengths and needs. Here's where you're doing real well. Here's where I'm like, let's try to tweak this, or here's some things we're anticipate as a barrier. And so we give a lot of support. If therapists need support outside of that, I'm on call 24/7. They can reach out to me. I've set up individual sessions, supervisions outside of that. So there can be a lot of support as needed. I also will go out to therapists to sessions as well.
It's like a live supervision.
Yeah, I love it. But I struggle, I'm not going to lie, I struggle not to take over. I know, Kate, I've done that to you. Where I go out and I'm just like, oh, it's so in me, I just want to jump in and do it.
Let you do your thing.
Yeah, I know, but it's not helpful. But I just love it. I love getting out with the family and doing the work. So I also will do that. Therapists also, like I said before, they have clinician development plans. So we formally update those once a quarter. But I actually work on those. I don't think they know this, but I work on them with them every week through supervision. So what feedback I give in supervision is based and tailored upon their goals and their clinician development plan. So they may not realize that, but I always have something going with their goal. It's done jointly, so it's kind of like a mini treatment plan. I have one. It's great. Typically what I'll do is I'll go over the day and say, hey, listen, this is where I'm feeling like I want to go on this for you. And then I have them pick a goal. So sometimes they want to learn more about, maybe I'm not so good in family therapy, so we're going to add a family therapy goal. Sometimes it's self-care. Sometimes it's, how do I manage a session when caregivers are just loud and they just they take over and I don't know what to do. So we tailor it to everyone. There's also a lot of training for MST therapists. Initial training at a company level, we do myself, and then I have shadowing, and there's a lot of support. But MST Services, who is like the head honcho of MST, they have a hybrid orientation model. So now it is e-modules, and then 2 days of in-person where they do kind of role plays and they really test out what was discussed and worked on in those e-modules. And then we get quarterly boosters on top of that, which they're my favorite. Also, we do it at my house, so my dogs are there, so it's kind of great. But we pick a topic, and we really get to learn about it. And then each therapist walks away from those boosters with interventions to use immediately with their families. So that's what I love. It's super helpful. I will do trainings. Typically, I did it once a month earlier, but if we're learning about a skill and there's a theme across therapists of maybe we're struggling with school interventions, I'm going to do an hour training 1 month on here's some interventions for school that I really think we could all use a refresh. So always kind of learning, growing. It's great, to be honest. So the great things about MST, we do the hard work, we get in there. We have pretty decent outcomes for the difficult youth that we work with. But I like that we take the model that we work with our youth for ourselves, for supervisors, and for the program. So there's a lot of accountability. We're never stagnant. We're always moving forward. Even when we have hiccups, we're moving forward. So, yeah.
Thanks, Elise.
Yeah.
So when you were talking about some of like the reciprocity in terms of the date, did I hear you correctly in that you said that the families actually rate how the therapists are doing on a whole host of different levels?
They do.
And then the therapists rate their supervisor on how they're doing. So there's
Absolutely.
sort of this bi-directional feedback loop that's been created.
Yes.
That's really cool. I didn't know that part of MST. I didn't know a lot about MST, to be honest. But that's
great.
That's great.
Well, it's great because the therapist, because you think you have 5 families, right? So say average 5 families. They each have one of those measures a month, they don't know which family rated them.
Yeah.
So when we pull the data, you get this slew of ratings, and we're able to pick out the trends. I can go in and see, okay, here's a trend for a family, because sometimes there's certain families that we struggle with more on certain items. So like, it's great because you don't feel targeted, right? Because someone's saying you're horrible at doing MST. It's, oh, I'm doing really well with these. I'm struggling on this item, maybe number 5, but we can work on that. So it's great. It's great.
I think that's, and I think it's so hard. We often get a lot of training. I mean, over the course of my career, I've gotten a lot of training, but we don't talk enough about the drift that happens after that training.
Yep.
And it sounds like MST has a model that's really designed to keep that fidelity at
Yes.
its highest level, and I think that's incredible.
Yeah, it's great.
When it comes to sort of, you also mentioned a couple of other EBPs that are utilized in MST. So you said cognitive behavioral therapy. You mentioned, what was the family therapy modality?
Pragmatic family therapy. So they'll do strategic and structural family therapy.
Okay, so strategic and structural family therapy modalities. Then you pull in contingency management and behavior modification. And so you pull all those different pieces in. And so I guess one of my questions is community mental health, right? Which MST is, which family-based is, which all of FLIP and PCS is, isn't for everyone forever, right? So for me, it is. I'm a community mental health lifer, but for a lot of professionals, they have designs on private practices or hospital settings, or like at a certain point in the course of their career, they don't want to be going out into the homes and communities and schools. They don't want to live out of their cars. I don't know why not, but sometimes that's a decision. When it comes to this being like that foundation of one's career or one of those early career opportunities, where do you notice your providers end up going on, and how does what they learn in MST kind of follow them for the rest of their career?
Yeah, so I've had, over the years, I've had a lot of therapists move on,
Sure you did.
unfortunately. A lot within PCS, which
Yeah?
is great.
I just hired one.
I know.
She's doing great.
I've hired 2, actually.
Did I?
Yeah, it's all right. It's okay. But I think the good thing about MST is you get your foot in the door, you learn a little about a lot initially, right? I tell people, it's very overwhelming. It is. I don't expect you to come in and know the answers. I don't know the answers. Sometimes I just wing it.
Yeah.
Usually I don't, but sometimes, or I do my consultant first and I'm like, hey, listen, like, help me here before I go to soup because I'm on the struggle bus. But you learn about a lot of different things. You have so many different clienteles and different systems that you work in. So I've had people that get in and realize, I really like the more mental health kiddos and the families that they really struggle more with de-escalation or those sort of things. But then I have other people that are like, I really like going in the schools and working with the schools and seeing what that's like. And then I have other people that are like, I don't want to go in anyone's house ever again, which is fair. So I think you get such an array of experiences that you get a little bit of everything, which is great because I think that kind of either tells you, oh, yeah, I'm really into this, or this is something I got to get out of. I've even had therapists that have gone on to be probation officers because they really like the juvenile justice system and the restorativeness and wanting to work at it at a different aspect. So it's different. I would say honestly, maybe 80% of the staff that I have had have left MST to do outpatient.
Okay.
Some have done it here. Some have done it elsewhere. Some will leave to do never private practice. It's always been like under an umbrella, but some will do school-based. Some will do specialized outpatient. That's usually where they go. I think I've had maybe 2 in 10 years that have said, I can't do mental health at all anymore and I'm out. But I will say most of them go on to do something in office that's not running all over God's creation in everyone's homes. So I don't know if that's a good thing or a bad thing. We may just tap people out, right? That's fair. But they always take what they learn and do something else mental health wise. So
No, you described like 4 different treatment modalities that lend really nicely to a bunch of different contexts. And I think that that's something that early career clinicians miss out on so frequently. They're like, well, I don't want to be an MST therapist forever. We hear it in family-based all the time. I don't want to be a family-based therapist for like, and it's because, I mean, the acuity is high, the work is hard. Once you're licensed or have more advanced degrees, sometimes there's higher paying opportunities out there. Sometimes the schedule's challenging. Sometimes people don't love living in their car. So there's a whole host of very valid reasons why people move on to other career opportunities. But my take-home message in any of these contexts is these community-based services are what are going to set you up for your career for the rest of your life. And they're going to give you tools and skills with fidelity that you can take into any context, even, I would assume, even private practice. I'm hearing CBT, I'm hearing family
absolutely.
therapy.
And I hire therapists knowing that a typical MST therapist, a seasoned therapist, lasts 2 to 3 years.
Yeah.
So I know that, I mean, we do have outliers. That's not true. We've had outliers. But typically, statistically, 2 to 3 years is what we have. I know that. So, but we're still putting it into you. We're still doing your CDPs. We're still working on that. Plus, I think those clinician development plans are key because it's not just, I'm not just saying let's work on like timelines or like policies. We're working on nitty gritty stuff. And that's things that you can use in your personal life, in your work life. So it's something that you can take with you and tailor with you for the long haul. So I think it gives you a great opportunity to really figure out what it is you like and dislike.
No, I love that. Wait, and I was just talking to another one of our supervisors last night about this new trend where very early career clinicians are going straight into private practice and bypassing like any of the more community-based programs. And I'm about to sound like a total dick, but I would eat you alive. In a private practice context. Like if you were a brand new early career clinician, I got some really good defense mechanisms. I've got some pretty good psychological training. I will see what you're doing before you're doing it. And it would be really hard for me to participate actively in therapy with somebody that hasn't had this level of support, this level of training, this level of really learning a model that you can lean back on. I think the endemic stress and burnout that we're seeing throughout our field, at least to some degree, can be attributed to this lack of therapeutic model and rather the therapist using too much of themselves within the room to the point where it becomes unsafe.
Yeah.
So I love that there's such a hyperfixation on taking folks with maybe not the most experience, maybe not the most training yet, but saying we're going to give you some really difficult cases, but we're also going to give you a tremendous amount of support, supervision, consultation, feedback, like that feedback and monitoring through the assessments, through the live supervision. And then after those 2 to 3 years, when enough is enough, you're walking away with this really well-defined toolbox with a number of resources to go into that private practice where maybe you have supervision once a week or once every other week. But I just don't think the ratio of 40 clients to 1 hour of supervision per week for an early career clinician is realistic in terms of developing their skill set effectively and serving their clients effectively. And I work with a lot of providers that like that's the due north. And I get that. Private practice, I think, would bore me to tears. Although I do really enjoy the private practice clinicians I'm getting to meet and building Live Up. So long term, that wouldn't be for me, but I just can't imagine where I would be today if it weren't for those experiences. Elise, as much as I'm loving the dialogue just between you and I, you brought some friends today.
I know. They're very quiet.
And so I am curious from the early career clinicians in the room, right? Because all of you all look like you don't use night cream just yet.
They're babies.
They're babies, but that's awesome. That fresh perspectives, recent educations. Y'all bring a lot of strengths into the room. From your perspective, what is kind of the best part of the role? What is the thing that when you wake up and you're like, man, I don't want to go do that today, and we all know those days happen. What is the thing that allows you to keep putting that like one foot in front of the other? What sort of keeps you coming back to the model?
I'd say largely the support that all of us get through whether it is each other as therapists, MST therapists supporting each other, or going to Elise. Like she mentioned earlier, there are definitely days that you leave a session and you want to cry in your car and you call her and she calms you down. And then you're like, all right, I can do this.
I'm just so glad to hear you cry in your car. It sounds so dark, right? But like you didn't cry in front of the client.
I will
win,
say-
win,
No,
win.
you hold
They
it
all
together.
wait until they
And you
they
cry in your
exit.
car.
And then you
from
cry
the
in your
client.
car.
It's nice to know nothing's changed since
And,
I.
and you call your other therapist and you tell them what happened. And then you're like, you got it. Pull it together. Keep going. And, trying to focus on the strengths, I think, is also another benefit and kind of thing to
And such
hold me personally there.
a unique part of MST when it comes to serving justice and adjudicated youth.
Yeah.
I feel like so often when we're dealing with children and adolescents that have a history of criminal background or some of those more criminality-based behaviors, must they have charges to qualify? No. So if they're engaging in behaviors that could elicit charges, they would qualify. Okay. So, to me, often those narratives are so problem saturated and the caregivers are so almost pathologized or like it's their fault. And it's just beautiful that there is a treatment modality in which we look at the strengths and we try to grow those strengths. One of my favorite metaphors is like when you walk into a dark room, you don't try to box all the darkness up and put it in a closet, you turn on a light. And yet so often as therapy providers, we are so symptom driven. We're so focused on getting the darkness away or out or in a closet, wherever we want to put it, that we sometimes neglect to say like, this is working and that is and brighten up the space. So I love that that's like the crux of the model.
Yeah, and I was also going to say, too, the most rewarding thing for me is just working with families and everybody involved. So like what Elise mentioned, probation, CYS, just like anybody involved at all, and helping them through their like absolute rock bottom with the kid and just seeing so much growth with like towards the end of treatment. So.
And I like that services are individualized for each family. We meet them where they're at, and try to help them move forward.
When I imagine it's not always a voluntary service, right? Is it?
Correct.
It's not always.
Sometimes it is court ordered.
Okay.
I mean, ideally, it's mental health, so it's always voluntary,
Yes.
right? They do court order.
You have an option. You can go to jail if you
Right. I mean, you have other sanctions if you don't follow through. So there's definitely some that are reluctantly being pulled into treatment.
How do y'all go about engaging those reluctant families or reluctant caregivers or reluctant adolescents and kiddos?
I think really meeting them where they're at and, acknowledging that, especially going into people's homes, it can be a little stressful, uncomfortable, and just, being really appreciative, empathetic towards the situation coming in. We really want to help in any ways that we can, and kind of emphasizing that we are really there for them. Because a lot of the time, these individuals have also had, other services and stuff in place that maybe weren't successful, and they're tired. They don't want another person coming in their home and working with them. So kind of showing that MST is different. I know I had a hard case with a kid who had some criminal charges, and he openly said, I'm not going to talk about my feelings with you. And we didn't go the full treatment, unfortunately. But, we would play checkers together. And through that, we kind of talk through his feelings, those kind of things. So really meeting them where they're at, and showing that we're on their side. We want you to succeed. We don't want you to, recidivize and go back to those charges. How can we emphasize those strengths that you got?
I would imagine that there are times where you probably get lumped into the rest of the criminal justice system, that they see you all as almost an extension of the criminal justice system, or they see y'all. And so I would imagine that drawing that distinction between I'm not your probation officer, I'm not your parole agent, I'm not I'm firmly on your side. But I imagine, especially with many of our clients having history of trauma, history of maybe challenging systems within their lives that haven't perhaps always treated them with the utmost respect or kind of the best, I don't know, standard of care at times. I suspect that you all often have to really draw those distinctions and help them understand, like, I'm here for you. I'm not here to chase you around and throw you in juvie at the end of it. My goal is to help you find a values-driven life.
Yeah, absolutely. And just being transparent, because a lot of times they are having those thoughts thinking that we're just like another individual trying to place them, or just like something negative like that they have experienced in the past. So it's really important for me to be transparent with them, and like, I'm not your probation officer. I want to work with you, meet you where you're at. And even recognizing, like, for low engaging families, like, any small positives there are, and praising them on that, I feel like goes such a long way, because they might not realize it. I know I had just like a recent like low engaging family, and we talked about like they're doing really well towards the end of treatment, and they talked about how much like I helped them recognize their own strengths and like positive steps, and that made them like feel really good to just like change things to that's influential on the kid's behavior. So yeah.
I would suspect most of these clients, this is not their first foray into treatment.
No,
Not typically.
not usually. I would say I would say at least 80%, if not more, have had some sort of mental health service.
A lower
before.
level of care
Yes.
at some point in time.
A lot of them have had outpatient, or they have gone to like an outpatient intake and then been discharged because they
didn't go
followed
back.
through. We've had quite a few that have had multiple rounds of family-based, had IBHS services previously, inpatient stays, RTFs. So like some of these they've been through the gamut of any service that's out there that's community-based. Some even not community-based services. So they've been through it all. And so sometimes we get them and they're just like, I don't want another person. Like, you're just going to do the same thing. I'm not doing that. So the good thing about MST with our engagement strategies is we have an unlimited choice of interventions to use. There's plenty of times that I say, listen, just tell them I'm going to bring some pizza. We're going to meet for dinner. I'll say, meet them out, because sometimes they don't want you in their home. I get it. Let's go meet at the park. Let's go meet, at the coffee shop. Food with teens and caregivers, true story, it gets you everywhere, Sometimes it'll be, even the caregivers will be like, because if the kid's 14 or over, they got to consent. So I really need that caregiver, but I still need that kid to sign. So the caregiver will be aligned, but he's gonna not want to do this. He's gonna put up a fight. All right, well, what is he like? Usually, I think at this point, all my therapists, their first thing is, what kind of snacks do you like, right? It's not a bribe, it's reinforcement. After you sign this, we'll have something fun. So we use those BMOD strategies out the gate. See?
There it is.
Yeah. Or sometimes just bringing, I'll say, why don't you stop by, bring them some flowers, or, something to show the caregiver too. We're not just here because you're mandated or you have a bad kid, as they, have that cognition. We're here because we genuinely see value in you and are concerned and want to help you guys function better. And so showing caregivers that, like, you matter. And yes, your kid is a tough kid. Teens are tough. But we care about you. So we'll take them some coffee sometimes. Just say, hey, I was thinking of you. I'm going to drop you by some coffee. I know you had a rough week. Take them some flowers. They've done self-care baskets for caregivers before, especially for working on like CBT sort of stuff. And like, so we have a lot of really good tools that we can use for engagement. So it's not just the typical, like, we're going to mandate you and really go on that route, because that doesn't lead to good outcomes. It's not sustainable. We do value them as a person. We do genuinely care. You're not in this field if you don't genuinely care. So showing that, and I think a lot of these caregivers haven't seen that before, but that's what's really helped and does help with our engagement with families.
Does MST have FSS funds or something comparable?
We
like
do.
have in Family Days?
We have something called flex funds.
Okay.
So it's per.
That's where the coffee and the
Yeah.
like. You're not asking these ladies to pay that out of pocket. Okay.
No, ma'am. No, they have flex funds for that. But that also goes to, like, we have a lot of kids that like to sneak out, or they have unknown whereabouts. So we have strategies of, do you guys need alarms? We'll help. We can use those to order alarms, cameras. We've recently got into air tags. Air tags and Jasmine, is it your kid?
Yeah.
One kid has one on a bike. One grandma has sewed a few air tags in different shoes.
Yep.
So we are able to use those things too to help with treatment, but that also helps with engagement. So we're not just giving them strategies and saying, you should try this, and whether or not you can afford it or figure it out on your own, we're really going to help you with
We're
that
going to
too.
give you the tools so that you can be successful
Yeah.
as well. That's awesome. I wasn't aware that funding was available there as well, so it's good to know. From y'all's perspective, we talked about a lot of the strengths and a lot of the really positive parts of the role. What are the more challenging parts of the role? What are the pieces that I don't know, lead to that not wanting to go to work in the morning or whatever it is? Tell me about that piece.
Sometimes I think you can get kind of caught in a loop with caregivers. You're really, like we talked about the do loop, you're really just kind of cycling through, reassessing barriers, and we are just not seeming to get to where we need to be with the interventions. That can be frustrating, and those are the days where I go into Elise's office and we have a personal supervision. So it can be hard. Some families definitely have more crisis than others, so that kind of plays into the 24/5 being on call. So that can be a lot sometimes. The locations that we work in can sometimes be a little iffy, but a benefit of the MST model and what we are able to do, we can take them out in the community. We can meet at parks and just kind of acclimate and adjust to what we need to. But there are definitely hard days with those hard cases because they are so intense, and we're really getting in there and doing the hard work and then getting out. That's why we're there for that short period.
Yeah, and sometimes with some of the families that are more tough, it seems like that 3 to 5 months isn't long enough. And I feel like I want to spend more time, but I know I can't. But then I just remind myself we're just there to like plant the seed, We can't always be there.
Yeah, and I mean, kind of with what Kate and Gabby said, just like sometimes when we deal with a lot of families that are just like putting a lot of their frustrations out on you, it can be overwhelming for sure, and it can be challenging. But it's really crucial for me to remind myself, like, they don't mean it personally. They're just going through a lot, especially early on in treatment, because they don't know, what we're going to do in MST. Like, obviously that's when a lot of things like the behaviors are really bad because we haven't really dived in. So that would probably be one of my biggest like challenges, but it's really rewarding, like I said, to see it flip the opposite way towards the end.
Yeah, I mean, I think at times, we don't always have caregivers that want to be in treatment. And sometimes it almost feels like they want to test your boundaries and see if you're going to stick around. And they push your buttons just like, the kids and parents are pushing each other's buttons. And kind of overcoming that, powering through, and like Jasmine said, it's not personal. They've had a lot of people in their life maybe not really support them as they needed. So, powering through that, really overcoming the barriers that come up.
It's a time-limited service. You're there for 3 to 5 months. It's acute stabilization and then some titration, I'm assuming. Where do clients tend to go following their time in MST? What's the next step in a successful case or in a case that went according to plan, so to speak?
I would say definitely like maybe just like having increased engagement with school or even a job. That's definitely one of our goals. Sometimes just like even like just maintaining other pro socials too, just so we see like progression and not necessarily regression as well.
And depending on where the family is at and the child, as well as the caregivers, sometimes we recommend like outpatient services, or like, Jasmine mentioned was school. Sometimes we do school-based as well, just depending on what the kid needs. If the family is still struggling, sometimes they transition over to family-based. I know that's happened before. But yeah, we definitely, I know, try to keep them in services so they have that continued support once we discharge.
How do y'all ground yourself in the work that you do?
Oh, Lord, does this mean silence means we're not grounded in the work?
I don't know.
Oh, no.
I feel like the support of the team is what's really helpful for me and Elise. I mean, there's no one better than Elise out there.
Oh, Lord.
No, seriously, I call Elise like almost every day, or she sees my face in the office. So I feel like the support from the team we have a really good team. And then we also started doing trivia once a month. Nice. Yeah, so we're trying to do stuff like outside of work to get together and decompress.
Yeah, they have a nice little, it's always kind of been this way. Not when I first started MST, but maybe like a year. Everyone, no matter therapists come in and out, but they all kind of within their team and as a whole have a very good rapport and support with one another. So yes, there's group texts that I'm involved in, but they also have their own group texts that I'm not involved in.
Of course.
Goodness knows what's in that. But so they have their own little support system going on. They have stuff, going on outside of like, work and things that they do together, and really, so I think a lot of their support of each other is almost like, I don't want to speak for you, but I think that's like the biggest thing for them is that support from each other.
Yeah, absolutely. And with that, I would say like another factor that I stay grounded is just like with the flexibility we're able to have, like giving myself grace. Like, so right now I like usually work home from Fridays to make sure I catch up. That's kind of my self-care of also working, but also like making sure that I'm still aligning with my caregivers, like in families' schedules, but that's something that helps me. And then enjoy time on the weekend and go hiking or spend time with my dog, eating sushi, stuff like that.
You do have a cute dog.
He's so handsome.
He's a handsome boy.
Like post a picture in the video.
So part of the How to Be Happy Hour is that we accept questions from those sort of out in the community. And unfortunately for this particular one, we did not receive many questions.
I'm not shocked, because no one knows MST.
Because no one knows what MST flippin' is, which is why we're doing this in the first place. We do have a few upcoming pod topics, and we are accepting questions for those. If you have a question on either of these topics, one is about the food-mood connection. So how does what we eat impact our mental health? How does our relationship with food change over time? So that food-mood connection. And so if you have any questions based on that particular topic, you can email me at kim@howtobehappyhour.com. Also, our topic after that, we're going to do one on weird self-care. All the different ways that people get weird in service of their own wellness in difficult jobs. Because I'm a big fan of weird self-care. Bubble baths are great, but have you tried twerking while doing chicken chores? I don't know. Maybe you should. So those
Is that
are.
one going to come with video clips of people engaging in these?
There are no videos of that particular behavior.
Well, maybe not that one in particular, but I'm just wondering, like, are we going to get descriptions of these things?
Yes.
Okay,
Yes,
because I'm
for sure.
Okay, I'm definitely tuning in for that.
For the weird self-care. Yeah,
I don't
I'm
know that I
excited.
have any weird that I could. I probably do, but we don't need to talk about it. But I'm definitely going to be listening to that one.
So those are our upcoming topics. Any questions, please send them to kim@howtobehappyhour.com. So y'all also brought a few like prepared pieces here today. Is there anything that we haven't naturally kind of arrived on? Is there any pieces that have been left unsaid or points that from y'all's perspective, either if you are a family thinking, I want MST services, Maybe you're a referral source and you're thinking, oh, I've got a family for MST services. Or maybe you're an early career clinician or a more seasoned clinician that's saying, wow, that modality really calls to me. That really speaks to me. Are there any bits and pieces that we missed? I know Elise provided an incredibly comprehensive overview, but are there any parts that y'all came here today sort of weighing on your heart that we failed to address so far?
We kind of touched upon it, but when I applied for this job, I really liked just like how the job description looked to where I wanted to work with underserved populations. So lower SES families. Not that all of our families are like that, but we are a good resource for that. So that's something that I find that's like really rewarding, that I really like, just because it's providing them resources that they maybe are not aware of or that they didn't think they could have access to. Also, like kind of the interventions that we do, like for monitoring, like we talked about the air tags, just brainstorming with families, just new ideas. So like kind of tailoring or tying into that, just like that lower SES, like, and just like providing that individual, I'm sorry, I'm like struggling here, individual, just like stuff that might be new to them for sure.
It sounds like you have an opportunity to get really creative in
Yes,
service of that individualized treatment plan. I hear a lot of different modalities really like tout that as a value. And then if I look at one provider's treatment plans, they all look the exact same. And there isn't that individuation. And it sounds like in MST, you can really get creative and look at it by behavior by behavior by behavior and address it in a way that's more effective.
Right, and customization is basically what I was trying to say.
Yeah, no, that makes sense.
Yeah.
Any other bits and pieces that we failed to mention or that y'all think would be useful for somebody who's considering MST in some capacity?
I think emphasizing the wide variety of clinical experience you get in the position. So whenever I was getting my master's degree, I was at RBT. So I'm definitely familiar with the behavior mod. And then kind of transitioning into this, being able to take what I already knew and what I had learned in my master's program and apply it and really see how, involved we can be and all the different interventions like the air tags. In outpatient, you're not sticking air tags in kids' shoes. So
No, these kids don't come to outpatient. They don't even come to the office.
No.
You don't get to see these kids
Exactly.
in outpatient because they're not coming there.
No.
You have to go to their house. You have to go to where they are.
Exactly. And just, all the different things you see. No case is the same. And just all the different clinical skills that you use on a daily basis with clients. And just, the workarounds that we do to really help the families in any way we can.
No, and as you were speaking, and then I feel like you just reinforced it. I think the division between like the haves and the have-nots in the United States seems to be getting wider and wider. I don't know if this statistic is still relevant, but I know once upon a time, Dauphin County specifically, are you Dauphin? You're Dauphin because you go to Elise's office, so you've got to be Dauphin. Dauphin County was for the longest time in the state of Pennsylvania the most polarizing when it comes to income levels. So Dauphin County had the lowest of the low and the highest of the high, and then just sort of everything in between. And I know Pennsylvania Counseling Services, like one of our primary, due north, what we're driving towards is serving underserved populations or more traditionally underserved populations. And I think in service of that, MST is very much in alignment with that specific value. But it just sounds like you have so many other opportunities to reach a population that otherwise their needs would just go unmet until they find themselves in some sort of institution.
Yeah, or I think I tend to also err on the side of everyone is worth the support. So even if they are resistant, I think it's worth a shot. So that also does technically sometimes hurt our data if we look at that overall. But these are families that a lot of people have already said no to, or they look, no, this is too much, we can't do this. And so they've gotten a lot of no's, and they really don't have any other resources. So I think it's almost like, you know what, it's worth a shot, and it may not end up with us hitting our ultimate outcomes, but we tried. They're valuable. They're worth that. Our community is worth that. But also, like, maybe we just change one small thing for them, and I'm okay with that. Maybe we got them to the point that next time they're not going to just be bucking the system and saying, no, I don't want service. No, I don't want service. Maybe next time they'll give it a shot because we were persistent and we helped do something for them. So I think that's one good thing about us is, and which does sometimes make it difficult because I do keep some cases that are real hard, but they're worth that.
Yeah.
And a lot of other people wouldn't give them a shot, and that's sad and frustrating, but they are worth it. Yeah.
No.
I hope you don't mind me sharing something that you told me, like whenever I first started.
Oh, Lord.
And it was a horrible case.
I love when people say that. Something you said really stuck out. And I'm like,
A year
what
ago.
did I?
Yeah.
I know, but a year ago. so
In
this
like
could be-
November. Yeah. So it was a really, really difficult case. And one of them that I was just like, I don't know how to keep going on this. The ups are great and the lows are the worst days ever. And, you know, this family had been failed by a lot of systems.
Yeah.
And calling and just being like, I don't know what to do. I don't know what to do anymore. And you told me, if we don't help them, who is going to at this point? And I think that always really stuck with me because these families have been, you know, passed up, fallen through the cracks.
Yeah.
And we provide support and, you know, encourage them in their resilience because a lot of these families are so resilient. They just haven't tapped into it yet. And encouraging that is really rewarding.
Or they don't recognize it yet, right? I mean, for me, that's like the goosebump moment for me in therapy. Like when I sit and reflect on my client's story from start to finish, and I'm like, holy shit, like foster care, justice system, gang involvement, drugs, gun violence, like all these different parts of their story. And it's like, man, if your story was my story, would I wake up in the morning? I don't know. Would I be in my office, or would I have like put on shoes today? Perhaps not. So it's just incredible to me that when you really zoom out and reflect on all that many of these families have overcome, or even these adolescents, like these tiny humans that have, like they don't even have half their brain that they're going to have when they're adults. That hasn't even shown up yet. And you think about all that they've navigated with that partially formed brain. It's just incredible. But so often, I think our brains go to what's wrong or what's broken or what's not fitting or not working. But that resiliency piece can just be so powerful when we let it in, when we are able to see it in that space. Anything left unsaid for us here today?
I will say part of a plus for just like anybody that's interested in working for MST, I am in a graduate program. So
cool.
I go to Elizabethtown College and I'm studying in the counseling psychology program. So I just am about to finish my first year, and it's a full-time program and I'm working full-time. And it's really awesome that the job is very flexible to accommodate those needs. And also I'm entering practicum and internship in a couple weeks.
Okay.
So providing the supervision and support, additional from what Elise is providing too, is just awesome, and is also like really just like great of a resource to have too.
So you're able to use your work as an MST therapist to
Yeah.
fulfill your internship and practicum requirements for your grad school
Absolutely.
program. That's incredible.
Yeah, and it definitely depends on the program, but
Yeah, they won't all
Elizabethtown,
let
like, you know, they definitely were working with it, and they love the fact that like MST is a family therapy too, so that's really like introducing me to a lot of modalities that I can really use anywhere, like within the just like the field.
And I'm obviously biased, but I think couples and family therapy is like one of the most effective types of treatment. And so often, when I'm hiring outpatient therapists, or even like live up counseling, independent contractors, like licensed providers, so many of them are like, I'll do anything but not family, not couple. And it's like, man, but if you do that, you've got like a superpower.
Yeah.
So I think that's really cool that you're able to kind of take that and pull that throughout.
Yeah.
anything else that we didn't say that should be said before we end here today?
I like how everyone looks at me. Here's the thing. I could talk about MST all day.
I know you could. I know
Like,
you could,
if
girl.
you're going to keep asking me, I'm going to be like, yes, let me fill you for the next 8 hours.
Let me
But
tell you more.
I feel like we did good today. I feel like we did good. We had the key points.
Yeah.
Excellent.
Yeah.
Well, then before we end, would y'all, and you didn't know or you didn't prepare this, so you may not have something readily available, but do y'all have any de-identified wins that you could share? A circumstance or a situation, a client story without any identifying factors that can kind of use as an example of how MST can kind of change circumstances in that really short 3 to 5 month time frame.
I mean, there's a lot
Yeah.
I can
Yeah.
think of.
Okay, so the
I'm
silence isn't on a basis of like we've got nothing.
No,
There's
we're
so
going,
many. Which do
we're
I
going
pick?
through the
That's lovely.
Rolodex.
Okay.
In my brain. You can't give any suggestions because you can't give any identifiers.
I think you should speak from the heart. So what is one that immediately jumps to the forefront of your brain?
It wasn't a successful discharge, but
That doesn't mean it wasn't a successful
Kid-
treatment.
exactly. And kid running the streets, he was not coming home. Involved in a lot of criminal activity, a lot. And he was a individual who engaged in runaway behavior, would stay in like trap houses and not good areas. And it was a very, very high risk, high concern situation. I actually chased this kid through a parking lot whenever he eloped. I'm in a full pantsuit and like wedges chasing a kid through the Bass Pro parking lot. It was an interesting day that day, but
And he yelled at some random woman.
oh my gosh. Yeah, it was an interesting day. But the progress that the caregivers made, so he had eloped. We had caregivers going down to corner stores, showing pictures of this kid. Do not let him buy vapes. If you see him, this is my number. Please contact me. Going out, hanging like runaway posters, posting on Facebook, contacting informal supports. All of these things, and we were only open for, I don't know, a month. And
That was like the first week.
it was intense, but going from caregivers who, didn't feel like they had power in helping this child with these behaviors. They didn't know what to do, and just how proactive they were with boom, boom, boom. We got these interventions, and the child unfortunately did get placed, but all that, action that the caregivers took, and really showing growth on their end. Just so much improvement on supervision, monitoring, and just being proactive and really attacking the behaviors when we can to better the kid.
Yeah, and that was a kid who had children and youth involvement, probation involvement, case management. They had family-based multiple times. They had family-based currently for another kid in like the grandma's house. So they've been through they've been through it. But the thing with them was all those formal supports, they've also been through it with the family too. And their outlook on this family was so pessimistic because they're like, this family doesn't follow through. They don't do anything. They let this kid do whatever. And you know what? They weren't empowered before to follow through. So they were also, I remember children and youth calling me and like, I can't believe there's missing posters up. And I was like, I know, it's great, guys, it's great. But they were just astonished. So overall, no. Data-wise, outcomes don't look great. But if we look at case-specific progress, those caregivers learned new strategies. They got success with implementing them, right? Because that's the key, right? They're having some form of success. They're going to take those skills, maybe not tomorrow, But maybe in a year from now when he returns home or with one of the other kids, they're immediately going to be able to generalize that. But also the key stakeholders could see that family does care, because that's also the thing. Then they start to get those negative cognitions. They don't care. They're bad parents. That's not the case. That's not the case. They just are so, they lack hope and they feel defeated. And so the fact that Kate was able to help empower them, get them to follow through, help change those caregivers, but even change how the formal systems looked at those caregivers now, that's huge.
Yeah.
And that's going to be helpful for this youth and the siblings moving forward. So not necessarily sustainable outcomes if we look at what I'm looking at for data, but personally for that family, huge, huge.
Right. And I mean, even as you're talking, I'm thinking like, I am a parent, so I've got 2 of my own kiddos at home. I can't imagine the experience. No, I can imagine. I've had the experience in which my child was struggling and I felt helpless to do anything. And I can tell you that from a parent perspective, just how deeply painful that was. So I suspect as you're describing the course of treatment with this particular family and this particular adolescent and set of caregivers, you gave them hope. You gave them options that were effective,
we
agents
did it
for
with
change,
them.
and you did it together in a way that empowered them versus doing it for them. Because I'm sure you can make a flyer and post it all over town, but that's not going to change the system. So it sounds like this particular family, while their data wasn't good, we would put them in the win column.
Absolutely. Absolutely.
Yeah. There's a lot of
I consider,
successes.
I consider that success.
Yeah.
Honestly, that family, I consider it successful.
From where we started, I think, there was a lot of cognition changes, not just with the family, but with, the key stakeholders, like you were mentioning, but the family's cognition of those people, these people don't have maybe as bad of a thoughts of me. At the end, family was collaborating with both CYS and probation. Previously, whenever we started, they were like, leave us alone.
Which
I don't
never
know.
works with those 2 organizations.
it's so funny.
Never a good way to get out of that
Keep
system.
showing up wherever you are. It's crazy. But just, really changing that. And I think that really affects the systemic part, like Elise was saying. Lots of wins. Maybe not in data, but,
But
in the...
all the other stuff that those caregivers did to make change,
Yeah.
that's what matters. That's what matters.
That was my
And
discreet
what would have
win.
happened? Right, but what would have happened if we weren't involved at all? If we didn't try, what would have happened?
Yeah.
I don't know. Maybe they would have gotten it together and they didn't need our support. That's possible. But yeah, MST
Maybe.
has a little ego, so I think maybe like we did have some positive.
Probably, but, they had a lot of strengths just in themselves. We just
They
gotta
Absolutely did.
work
Shined a
on
light
those.
on them.
Absolutely.
Well, thank you all. Thanks for joining me here today, talking about a treatment modality that you all obviously know quite a bit about and feel passionately about. I really appreciate you all coming and sharing, especially one of those like feel good outcome stories, even though the data didn't reflect it. And I think that that's like the secret sauce of treatment. Sometimes we forget to pay attention to some of those pieces. So in terms of next steps and the How to Be Happy Hour, we've got 2 upcoming episodes. We've got the food mood connection coming up next. And then after that, weird self-care. Thank you so much. We'll see you next time.